behavioral health, and suicide has culminated in her agency undergoing a year-and-a-half-long effort to become a trauma-certified provider of behavioral health services. As always, we would like to take a moment to remind you that Iris will be muting all lines. There will be time for questions and answers after our presentation concludes. If you have questions during the webinar, please feel free to type them into the question and answer pod. And we would also like to just take a moment to remind everyone of our upcoming events. And if you can find the email from Iris Colon-Burchett, all of the information for registering for those upcoming events, Learning Collaboratives in September, both on Eastern and Western PA, our QI Boot Camp in November, as well as our conference in October. And at this time, we'd like to turn it over to Linda. So Linda, thank you very much.
Oh, you're welcome. It's a pleasure to be here today. Vicarious Trauma in Pediatric Physician Practices. How this developed was a few months ago, Dr. Carol Belinsky, and I don't know if her or her staff is on the line, but Carol is a pediatrician in Schuylkill County, Blue Mountain Pediatrics, and she is our Garrett Lee Smith site. She's been doing the risk assessments since day one, since we started the project in our county, and we've developed a close working relationship because of that, and they do an excellent job with that. And I'm going to say about 3-4 months ago, Carol called me. Usually she calls about something going on with one of the children and getting services or getting crisis involved. But this time she said, basically, my staff's burned out. Could you come out and help us? And I developed this based on that request. What had happened is they were involved with some families, as you all are, that might have been abusive, discipline techniques were not appropriate, and it was just wearing on the staff. So I went out there and we did this over lunch, and Carol then passed it along. So I hope it's as helpful for you all that as it was for Carol and her staff. The objectives, as you can see, understanding of vicarious trauma in the workplace and how it affects you, to become aware of the work setting and your individual response to vicarious trauma. And let me add to that objective, we have all been traumatized in some way or another. And our response to our individual traumatization will impact our vicarious trauma working with the population we work with. And the last objective is to understand healthy responses to trauma and how to develop continual support in the workplace. What is trauma? And this is a definition from SAMHSA. Individual trauma results from an event, a series of events, or set of circumstances that are experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. When you read this definition of trauma, you apply it to your patients and their families, but also apply it to yourself. As I said, we've all been traumatized. Our response to that traumatization is what makes us who we are today. So it's important for us to realize with ourselves, with our staff, that we have all been traumatized and that the families that come to us have also been victims of trauma. There are 3 E's of trauma: events, experience, and effects, and we'll talk about each of them in more detail. Excuse me. What are the events? You ask the question, what has happened to you? Ask it of ourselves. You could ask it of our patients and their families. The events are what cause trauma. We've been witness to, we've seen something, an event that has been traumatic for us. The experience, the individual's experience of the event determines whether it is traumatic or not. One of the things in behavioral health that we have to caution ourselves, especially as we're becoming more trauma-informed and trauma-certified, is just because from the outside looking in, an event would seem to be traumatic through our eyes, it may not be traumatic for the person experiencing it. So it's the person's individual experience of the event that determines whether or not it is traumatic. Always remember that. Like I tell my therapeutic staff, don't make it a trauma for one of our patients if it's not a trauma for them. So we have to caution ourselves when we do that. And the effects. What are the effects of trauma? They could be physical, psychological, social. One of the definitions of trauma is the effects of trauma, normal response to an abnormal event. Yes, when we experience trauma, we are going to have some physical, emotional, psychological reaction to it. That's normal. What becomes abnormal is how we deal with those effects of trauma. Some of the other effects of trauma are short-term or long-term. And that has to deal with how, when, where, and how often. If people are exposed to repeated traumatic events over time, how long, obviously the effects are going to be more intense. Let's go back and talk about some of the events. And I tried to couch this in terms of what you might see coming into your practices. Abuse, physical, sexual, emotional, psychological, and neglect. And as abuse, you could be the victim or a witness. Some of our families come to us where the children are not necessarily the victims of abuse, but they're witnesses to domestic violence or other forms of abuse in their household. Some other events that you might see happen to some of your patients and families are loss. The children have experienced the death of a family member, or they've been abandoned. You know, the children might be in the foster care system and are brought in by foster parents. Other events that may happen to them are accidents. You probably see lots of children who have been in some type of accident. Natural disasters. When they happen, that's an event that may be traumatic. I'm sitting in South Carolina right now watching the Weather Channel and thinking something's going to happen soon. And after those natural disasters, children have some traumatic effects. Chronic stressors. These are other events that affect our patients, such as poverty, racism, other traumas of other family members. What we're seeing now with children in families where there's substance abuse, that is a trauma. And there's more and more research being done on that area of children raised in families where there's substance abuse issues, and it is developing into a trauma for these children. Once again, I'm sure in your practices you've seen some of this. And remember, with all of these things, it's the how long, how often has the child or the patient been exposed to the trauma. Some information about children. 71% are the number of children who are exposed to violence each year. 3 million, the number of children maltreated or neglected each year. 3.5 to 10 million children witness violence against their mother each year. 1 in 4 girls and 1 in 6 boys are the number of children who are sexually abused before adulthood. And 94% of children in a juvenile justice setting have experienced trauma. So obviously, you're seeing children who fit into some of these categories. So that's your practice. That's the children you see. That's the families you see. They've been exposed to trauma. They come to you. You as an office staff have to deal with them, and that's what vicarious trauma is. The cumulative transformative effect on the helper of working with survivors of traumatic life events, both positive and negative. In the old days, we used to call it burnout, compassion fatigue, secondary traumatic stress. Who is affected? Law enforcement. Obviously, law enforcement comes upon the scene of some horrific tragedies. First responders, once again, ambulance, EMTs. Attorneys, judges, and juries viewing evidence. This is a new area that we're paying more attention to in the trauma field, and it came out of Philadelphia. There were some horrific deaths by child abuse cases over the past few years in Philadelphia. And one of the social workers in a community agency who happened to be involved, the judge pulled them aside and said, this is very hard for juries, attorneys, and myself to see. They were viewing evidence. So obviously some work to be done with that population as well. Clergy, once again, clergy gets called to scenes of some horrific traumas. The media. Good or bad, the media is involved in covering things in life that are very horrific, very traumatic. There are some people in the media who have a very strong trauma response and are experiencing vicarious trauma. Child protective workers. There are children and youth caseworkers. They get the call, they have to go out, remove the child, do the investigation, so on and so forth, obviously exposed to some traumatic events. Victim advocates. Once again, a victim of a trauma, in the system working with a victim advocate, they once again are exposed to the traumas that their victim has been exposed to. Behavioral health counselors. Being in that field for such a long time, I've heard a lot of things. And just when you think you have heard it all, you hear one more trauma, one more life event that's happened to one of our consumers. And then last but not least, medical personnel, all of you. You see it, you have to deal with it as a responder sometime. You have to deal with it as the after effect being referred to you on an outpatient basis. And what do you do? What do you do with that trauma? How does it affect you? What traumatizes you in the workplace? And I want you all, especially if you're in a room with fellow staff members, to really think about this after this little presentation. What traumatizes you in the workplace? Seeing injuries due to physical abuse or neglect. Have you had children brought into your practices with those injuries? If some of you have worked in emergency rooms, you've seen those kind of injuries. Actually, in your practice, do you witness abuse? It's usually verbal or emotional. In my work with Dr. Belinsky's practice and some other practices, the staff have told me numerous times of hearing parents say things that they feel is very abusive. And what do we do about it? We know what we do with the child abuse reporting law, but how does it make you feel as the staff person witnessing that abuse? Sometimes when you're working with a patient and their family, you have very strong responses to their parenting styles. May not be the definition of abuse, but some parenting styles are not as positive as others. How does that make you feel when you're in the room and listening to a parent discipline their child in a way that you feel is not appropriate? Another type of situation in the workplace, parents demanding a specific treatment or medication. Not only in pediatric practices, that happens on the behavioral health side as well. Parents come in, they think this should happen, that should happen, this form of treatment, or that medication. It puts us in a very difficult position because we want to be helpful. We are the provider. We want to do something, but if it's not what the parent wants, it can become adversarial. Another thing that happens in your workplace is lack of parental follow-through. You've worked hard to get the child what they need, and the parents don't follow through. All of these things are situations that may traumatize you while working with your patients and families. What happens to you, the worker in the medical setting, when these things are witnessed? What is your vicarious trauma? Do you become overly emotional? Does it upset you to see or hear those things? Emotionally shutting down. Are you so overwhelmed and have seen and heard enough that you just can't deal with it again? Feelings of loss of safety. Sometimes when we see abuse situations particularly, it makes us question our safety. Physical response, illness, fatigue, absenteeism. For those of you who are managers in the practices, keep an eye on that. We all keep an eye on absenteeism. What's going on with our staff? Illness, fatigue, absenteeism could be a response to trauma. Feelings of being on edge. Do we constantly feel nervous, or do we get anxious when we have to go into a particular patient room? Reduced motivation and productivity. If you come to work and you have those feelings, oh, I just don't want to be here, I can't do it again. I can't go through another day of hearing these things, of being traumatized by what's happening to our patients. Frequent complaining. Do we complain about our job? I think we all complain about certain things in our job, but is it ongoing and frequent? As managers, listen to what your staff is saying. Sit around the lunch table with them and find out what is bothering them. It may not be the hours, it may not be the pay. It may be responding to the trauma of the patients. What does this mean for the work setting? If you have staff who are victims of vicarious trauma and experiencing some of those responses that were on the previous slide, what does it actually mean for the work setting? First of all, staff turnover. You get workers who come, do the job, vicarious trauma sets in, it's not responded to or dealt with, they're going to leave. They're not going to continue to work in that setting. Low productivity. They may stay, but not be real productive workers. Lack of trust among colleagues. I think we assume that the people we work with should know what we're going through, what we're seeing, and what we're hearing. And when our colleagues don't respond, we may think it's because they don't care, and we develop a lack of trust. We have to be open about these things. We have to talk about them. Our colleagues may not know that we just came out of a room and witnessed something that upset us. So we have to develop openness and trust among our staff, among our colleagues. Feelings of lack of support from management. Once again, managers sit down with the staff at various times, whether it be lunch breaks, things like that. Ask them what they're seeing, hearing. You know the medical piece. You all know the medical piece very well. But it's those other things that happen in the room that you have to ask about. What else happens? A less compassionate workforce. That's a typical response if someone's burned out. They have no more compassion. Just can't do it anymore. I don't want to do it anymore. And if all of those things happen to the workforce, you're going to have less satisfied patients. They will pick that up, not understand it, but get that feeling from your staff that they just don't really want to do this. How to develop healthy responses to trauma. And as I've said numerous times, we've all been exposed to trauma. In the field you work in, you're exposed to trauma vicariously. So how do we develop healthy responses to trauma? What is your self-care plan? What do you do to help yourself feel better after work? I went to a training once, and someone said they worked in a very traumatic medical setting in an emergency room in a large city and saw lots of things, lots of horrific things, and said, well, I went home and I'd have a glass of wine. Oh, okay. And then when I got to 3 glasses of wine, I thought, oh, I better start talking about what's bothering me. And then when I got to a bottle of wine an evening, I knew I had a problem. So monitor yourself. What is your self-care plan? Monitor your sleep, eating, and drinking patterns. Monitor your emotional responses, and that may be based on your trauma history as well. So you really have to look inside yourself and get a feel for your own trauma history and how you're responding. Some people respond differently to different situations, and I'll use the example from Dr. Belinsky's office. One of the LPNs who was currently pregnant and had a few children already and sees the role of being a mother and having children very positively, loves it, loves her family, and just sees that with great value. And she had to deal with a family where the parent, the mother, was very negative, very unhealthy in discipline techniques towards the child, and just very mean to the child while our nurse was in there. And she left that patient contact and was very, very, very upset. And reason being is that's something she values so much. She just found it very difficult to work with a parent who was so mean to her child. So monitor your own emotional response. Develop your support system at work and outside of work. And relating back to that incident with the nurse and the mother, sit around the table with your colleagues and say, look, you know I can't deal with people who just talk meanly about their children while the child's in the room. Maybe there's someone, one of your colleagues who says, well, I'll take it because I go in and just tell them to stop. You know, I have no problem. I can end the conversation and move on with it. So develop your support system around your work colleagues as well as outside of work, because there's someone in your work setting who might be able to do something or deal with a particular issue better than you, and we need to be able to reach out to that person. Also monitor your physical health. As we all know, the cumulative effects of stress and trauma is that our physical health will decline. So please monitor your physical health. How to develop continual support in the workplace. Trainings. Any training you can offer your staff about situations that they bring to you, please do. Staff debriefings. After a situation occurs, give staff the opportunity to sit down and talk with each other, talk with you as managers about how did we do? How do we do it better? What needs to change? And just let their feelings out. Particularly, I've talked with staff, even my own staff in behavioral health, reporting child abuse to the current system is a long process, and you don't sometimes feel like you're getting anywhere, and you don't know what has happened. And it makes my staff quite upset because they want something to happen immediately. So we have to sit around a lot of times at the end of the day and staff about those things, that reporting into the child abuse system right now, how it makes us feel, what will happen, we hope things are okay. So have those debriefings if someone comes out of a patient meeting and is upset. Know your limitations. As I said, each of us have strengths and skills. We can work with different types of situations better than our colleagues. Please know that among your staff. Team approach. Once again, it may take a few of you to deal with a particular patient or a particular family. And support from management. Once again, management, be involved. Find out what's going on with your staff. Find out what works for them in dealing with your patients and their families, and find out what doesn't work. The last thing is monitoring vicarious trauma with tools such as the ProQuil, and that's attached. I don't know if everyone can see it, but that is a scale, and I think you will be able to see it at some point. And we use it with staff, and basically what it measures is how staff is doing in responding to trauma. So it's been attached. It's free to copy as long as the author is credited and no changes are made and you don't sell it. So as a manager, a few times a year, if you want to sit with your staff, hand this out, have them go through it, and it measures things such as their satisfaction. Are they burned out? What they do if they're burned out. Do they feel overwhelmed in dealing with trauma in the workforce particularly? Oh, there it is. So I think you all have access to it. If not, you can go online and find it.
Yes, it's there.
It's there. And make the copies. As I said, you have to credit the author. You can't change it, and you cannot sell the tool. We do this a few times a year with staff in behavioral health to monitor how staff is doing as it relates to working with trauma. these are the references. Please use them. There's lots of information. If anyone wants more information, you can email me, and I can give you lots of references and resources for vicarious trauma. Are there any questions?
Remember, for the folks that are on the phone, if you want to ask a question, hit #6 to unmute your line. And the Q&A box is always available also.
Sure.
Linda, we have a question here.
Hi, Linda. My name is Eileen Thompson. I'm with Medical Home. I have a nursing background, and I know a lot of issues I had when working in the field with both, practitioners, the staff, and clients themselves was Munchausen syndrome by proxy. And I just find that was something that totally traumatized all of us on staff, as well as, the client, obviously, himself, the child. But how do you suggest dealing with something like that, whereas, a child coming in with maybe bruises, like we can quickly, come to a resolution and have some help for that child. But Munchausen by proxy, I mean, you're really tied between a rock and a hard place in trying to prove that that truly is what it is. And I didn't know how you deal with that and helping, the staff in general, because it's a long process, like you said, with certain situations.
Yes. That's a very interesting question, Eileen, and Munchausen by proxy is a very rare diagnosed mental illness. It does happen. It is rare, but for the times it happens, it is difficult. Some of the things, two things you have to worry about. You have to worry about the child themselves, obviously. They're having some physical effects, some very serious at times, I would imagine, and also the psychological status of the parent, who is the one doing this. So two issues, the child's physical health care and the psychological state of the parent. Once there's suspicion that these are not just, bruises from a fall, or, the explanations just don't match up, everything else has been ruled out, I would think that the most appropriate action would be a report to Children and Youth, to Childline. At that point, once again, that's when my staff becomes even more stressed. They're not sure what's going to happen, how soon it's going to happen, how is it going to affect the child, and I understand that. But that, after the ruling out of any possible physical explanation, the stories just don't add up, that would be the appropriate response. But the psychological state of the parent, that's where we lose control of it a little bit, because that person would have to seek treatment themselves, and it's a very hard course of treatment for someone actually diagnosed with Munchausen by proxy. So there's going to be great difficulties involved for that family. If there were other family members, another parent or grandparents or someone else in the family who you could use as the child's advocate, if you will, that would be helpful as well. But that would be the official response to that situation. Now, what do we do as a practice when we have to see that and go through that process? As I said, reporting to Childline always causes my staff some stress. It may do the same for yours. But how do you deal with witnessing repeated abuse of a child is basically the situation. And once again, which one of your staff members have a high vicarious response to that? They should not deal with that situation. Send in staff who don't have such a high response to that kind of situation. So you have to find the right staff to deal with that situation, and then just support each other in that process. As I said, it's a very rare diagnosis, and I hope it doesn't happen a lot in your practices. But once again, you have to listen to each other, find out what's going on, find the staff member, your colleague, your team member who can help you process this case, if you will, and help everyone through it. As I said, I could see how that situation would be very traumatic for a practice, seeing a child repeatedly abused and being brought to the medical community. That's the interesting thing about Munchausen. You know, most cases of child physical abuse, parents aren't seeking out doctors. They're trying to hide it from the system, if you will. With Munchausen by proxy, those parents, those adults, do seek out medical attention. So they're coming to your office a lot. So you are being faced with this ongoing trauma experience for the child and for your staff. So this would be one of those situations where lots of debriefing after meeting with that family, lots of who can do this, I can't do it, I can't deal with this situation today. Whatever's going on in my own life is making me a little too emotional right now. So they would be the things I would do, Eileen, to help get through it, But the fact that you have recognized it, and hopefully some of the other practices, when it happens, recognize it, but can help their staff trauma to it is probably the best that we can do and the best that we can offer our staff.
Okay, great. Thank you, Linda. Linda, can you see the question in the question and answer box?
Let's see. Is there a scoring system or a score you should be worried about? There is a scoring system. Let me pull my version. If you go online, there is another page of this that gives you a score, and it tells you which items, you know, a score of this is higher and what's in the danger range, if you will. So if you're interested in using the ProQuil, go online and get all of the pages that go with that, so you can actually score them, and if you're going to use it as a tool with your staff, that would be perfect.
Thank you. Is there another question? I do see someone that's unmuted. Again, if you want to ask a question, it's #6, and if you want to type in